This conference will now be recorded.
Welcome, dear guests and dear friends, to the virtual hub of Online Cardiology Club. My name is Sercan Okutucu. I am an interventional cardiologist from Ankara, Turkey, and I will be moderating this online activity today. Firstly, for the ones who are new on this platform, you can write your questions or comment to the chat box, and we can ask them to our distinguished speaker during the session. And our today's session will be on therapeutic similarities of two really deadly diseases, namely STEMI and ischemic stroke. And we are really fortunate to have this important topic from an expert interventionalist, that is Dr. Estevao Martins. And as a brief introduction, Dr. Martins is an interventional cardiologist from the Rio de Janeiro, Brazil, and his expertise consists structural heart interventions and stroke interventions. He has a nationwide stroke intervention programs and courses in Brazil. And in addition to this, he is a great educator and kind person to accept our invitation. So I will not steal more time from this important event. And Dr. Estevao Martins, stage is yours, and thanks again.
So thank you very much, Sercan. I'm very honored to have this invitation from you to take part on your online club. It's really a pleasure and an honor. It's a great initiative that you are having in Turkey, and you, always, you are pushing the boundaries, Sercan. Just a brief word about our friendship. We met in 2018 for the first time in CAS mitral and tricuspid intervention in Zurich. And after that course, we attended another course that was CAS aortic course in Zurich as well, a course led by Dr. Francesco Maisano, Carlos Mestres, and also Francesco Taramasso. And we have been together for almost 600 hours. It's a pretty good time to know each other and to do this kindly friendship. So thank you for this invitation. And after saying that, I go directly with the presentation. So we are going to approach the topic therapeutic similarities this night. And therapeutic similarities between two pathologies, acute ischemic stroke and ST elevation myocardial infarction. For these, we have some learning objectives tonight that are to understand the therapeutic similarities between these two pathologies. And when I say acute ischemic stroke, I'm referring here for large vessel occlusion. Acute ischemic stroke is these strokes that have a large vessel, I mean the internal carotid artery, or even the M1 segment of the middle cerebral artery. That means a large vessel occlusion. To recognize the enormous burden of acute ischemic stroke worldwide, and also to identify the role of interventional cardiologists in the interdisciplinary stroke team. That are my three main goals in this presentation. If you get all of them, I will be very happy. And I put them as agenda as well, just to make sure that we will cover all these three learning objectives. So starting with the first topic, that is the therapeutic similarities. The first thing that we should do is to ask, why are you talking about similarities in therapeutics? So first of all, because there are similarities in the physiopathology that show you both of these pathologies are caused by a sudden and complete arterial blockage. Acute myocardial infarction are typically caused by a local thrombi, as you can see here in this picture. We have a plaque on the patient has a plaque, it suffered a rupture here, exposed to its inner content of the plaque, highly thrombogenic to the blood flow. It forms a clot here, thrombus, on top of a plaque, and you block the flow. That is the physiopathology of acute myocardial infarction. Acute ischemic stroke are most causally by distal emboli. It can be caused by local thrombi, but mostly by distal emboli. So we have a lot of sources here. The carotid plaque can generate embolism here, or even the carotid plaque can cause severe restriction to the blood flow. The aorta is another source. The heart is the major source of emboli to the brain. A lot of patients with atrial fibrillation, a lot of patients with valvular disease, a lot of patients with some akinesia in the left ventricle that can form some left ventricular thrombi. And even through thrombo that were created in the venous system that can cross to the systemic circulation through the patent foramen valley and also atrial septal defect. So the heart is a very big source of emboli to the brain. So why we are talking about similarities in therapeutics? Again, because there are similarities in the ischemic lesion progression. If you compare here, it's a very old picture, but very actual. Here, according to Peter Lancer, in a very good article that he wrote to the European Heart Journal in 2015, necrotic core here, necrotic core and ischemic penumbra in acute ischemic stroke correspond to myocardial necrosis and myocardial at risk in STEMI patients. So our goal here is to reopen this occluded artery to stop the progression of the necrotic core and try to save the ischemic here, the ischemic and under threat area of the brain in the penumbra. It's the same goal that we have in acute myocardial infarction. So we talk about similarities in therapeutics because both pathologies profoundly impact on patient lives. So from the aphorism, time is money, we have here in the acute myocardial infarction, the expression time is myocardium, time is heart, and in acute ischemic stroke, time is brain. So we should run to reopen an occluded artery. So you can imagine the disability, the functional dependence of this patient that suffered acute ischemic stroke here, and this patient that suffered acute myocardial infarction with only the basal parts of the heart contracting. You can imagine the impact of this disease in the patient's lives. And finally, we are talking about similarities in therapeutic because there are really similarities on the treatment timeline regarding the use of thrombolytics and thrombectomy. This, Sergeant, dear friends, is a very elegant paper, as I mentioned before, from Peter Lancer and Peter Widimski that was published in 2015 on Heart, European Heart Journal, just making a comparison between STEMI and stroke in the timeline. Here below is what happened with the STEMI therapeutic, and here above what happened with the stroke therapeutic. Despite the initial works, initial papers were published regarding the systemic lysis, in 1976 for both disease. STEMI started first to consolidate the systemic lysis in 1976. Then in 1979, we had some negative papers or trials with intracoronary lysis, but then we had good results with balloon angioplasty in 1982 and 1993. And then with the advent of stent in 1998 and 2004, we achieved here nowadays that the gold standard for STEMI is primary PCI. And if you cannot give it in 90 to 120 minutes, you can apply systemic lysis thrombolytics. So as I mentioned, they started to speak about systemic lysis in 1976, but only in 1995, thrombolysis was incorporated to the stroke workflow. and they got some good results with intracerebral lysis as well, application 1/3 of the dose of alteplase intraarterially. We got some questionable results with mechanical thrombectomy in 2004, 2009, but what the year that was the game change for the stroke interventions for mechanical thrombectomy was definitely 2015. Here we had 5 very strong randomized trials that showed us and gave us unquestionable benefit of this therapeutic. Are you hearing me well, Surgeon, until now?
It's perfect.
Okay, nice. So here in 2015, we had the game change. Mechanical thrombectomy on top of systemic lysis is the gold standard treatment for acute ischemic stroke of large vessel occlusions, acute ischemic stroke. So this is the comparison between both pathologies. So I would like to invite you to see 3 patients that I treated here in Rio. The first case is a case about acute myocardial infarction. It was a 61-year-old male patient with hypertension and dyslipidemia, history of a typical chest pain for 1 month, and the patient was admitted with intense chest pain with a delta time of 1.5 hours. The EKG showed ST elevation on the inferior wall, and as you can see here, the inferior wall with a very elevated ST segment. And you can see also in V3 and V4R, V3 to V6 starting to elevate as well. A lot of manifestation is EKG. Mirror image in lateral leads and also in V2. So the patient came to our cath lab with delta T 2 hours. Patient presented with ventricular fibrillation, was defibrillated with 360 joules and reacquired sinus rhythmus, but in bradycardia, 40 beats per minute. So that was the angiography of the left coronary artery. Okay, nothing to report here. But on the right coronary artery, you can see that it's occluded on the initial part of the middle segment of this artery. Then what we have to do is just cross the lesion with a guide wire. After doing that, we started to reestablish the flow, as you can see. A very modest flow, but we can also appreciate a thrombus here, a filling defect. And then we tried to aspirate, but the lesion was so critical that we could not. Then we had to do a balloon angioplasty, and here the flow is much better, and we could also visualize the thrombus hugging from the plaque. Then we did the aspiration using a specific catheter for that you know very well, aspiration device. And this is the radio part mark of this device. And after that, we could see that the artery was much cleaner, you see? And the thrombus was removed, but the plaque was still there. So this is what we removed from the plaque, from the artery. So we decided to implant a stent. And then this is the final result after aspirating and implanted a stent with a TIMI flow 3 here in this artery. So just coming back to our physiopathology of acute myocardial infarction, this was the lesion of aspiration. We remember that. You see that there was a fracture on that plaque, and this we could see very well here, and exposing the inner contact to the blood flow. And here we got a thrombus formation. It was hugging here, and we removed with aspiration, and the plaque we treated with a stent. That's the physiopathology with this result. So I invite you to the second case now. This case is just with a historical perspective. Okay, this is a female, age 65 years old. The patient went to do a carotid arteriography, but the patient felt some symptoms and became aphasic with right hemiparesis and left gauze preference. So we are called by the neurology team, and we got this patient with a delta T time symptoms about 40 minutes. The patient was already in the hospital. And now I introduced another term here for cardiologists, that the delta time here is the same as last time known well. This is a term that we will be using a lot. Last time known well, 40 minutes. The NIH stroke scale, about 15. The brain CT showed no hemorrhagic stroke. And the aspect, that's the scale that see the degree of impairment of the brain, was about 10. It's normal. So here's the angiogram that we did. There was occlusion at the left middle cerebral artery, as you can see here by the arrow. And this is the lateral view, surgeon. Dear friends, we are missing a lot of branches here in the middle cerebral area. And then at that time, and I say again, I reemphasize that this has just a historical perspective, just to see the similarities, but we don't do it anymore. But at that time, we didn't have a dedicated device, at least at that month when we attended this patient, when we saw this patient. And we used the Jedix right catheter with a guide wire, coronary guide wire. The patient could not receive thrombolytics in this patient because this patient had just removed the introducer. It was a 7 French introducer, you can imagine. So thrombolytic was contraindicated in this patient. The only thing that the guys could do is to reopen with coronary materials. The neurological team called me and asked me to do that. And it was we had to do. So I decided to do a very gentle balloon angioplasty here with a 2.0 sprinter balloon. And we started to see that the flow established a little bit here, but we could also notice here some thrombos in the middle cerebral artery. So I decided to apply 1/3 of the dose of alteplase and to do a mix of mechanical lysis and chemical lysis. And then the results start to become better, but still with a thrombus here in the superior branch. And then we did one more balloon angioplasty, very delicate maneuvers, very soft maneuvers. And then we got this final result. And I like to show this case. I reemphasize again, with historical perspective, we don't do it anymore for a while, because this patient was the patient that was a game changer for me as well. Because this patient was like clicking the button off, and then you click the button on. And the patient was aphasic, was hemiplegic, and she just started to talk with me and move all their limbs, all the right limbs, you know. So it was really a game changer, and I was caught here. I really was caught here. It's so powerful procedure. You can help so much the people that it really made my life completely different from this patient. And this patient is doing very well. You can notice that there is some embolization to a distal vessel here, but this territory you should not go. This is too distal. And the patient is doing very, very well. And we became friends since that time, almost 10 years of friendship. So if you see here in lateral view, that's a perfect image here. That thrombus is just here. So the patient didn't suffer anything with this occluded artery here. So after giving this perspective, historical perspective, I go now to the third case. That case is another acute ischemic stroke that I treated with a dedicated material now. Now we come to the real world with dedicated materials that is much friendly to use, much effective, and much more, much secure. So here it's a patient with a female, again, 73-year-old. The patient presented to our hospital. They came from home. She came from home with aphasia, right hemiparesis, left gaze preference. The delta time symptoms hospital was 2.06 hour. NIH 17. Brain CT showing hyperdensity on the M1 segment of the left middle cerebral artery. The aspect was 7, it's a borderline aspect. Some brain had some injury. Some part of the brain had the injury, but the limit is 6. The angio-CT showed the occlusion of the temporal branch of the middle cerebral artery. And I get your attention for the angio-CT. That is our EKG. This exam here is the one that will say, oh, you have to do the mechanical thrombectomy, or you don't have to go to the hospital or to do the thrombectomy. It's like our EKG showing a ST elevation. So the angio-CT showed a large vessel occlusion, and then the patient arrived to our cath lab with delta time symptoms to arterial puncture of 2.50 minutes. So here, dear friends, there is a more delicate procedure. If you compare to the last one, it's a branch that's the early bifurcation of the middle cerebral artery here. There's a tortuosity as well, you see. And here, definitely we should use dedicated device. It's a video. You can see that it's a dedicated guide wire. The microcatheter tip is here. We can advance both with very soft maneuvers. The first thing we have to do is to inject through a microcatheter to see if the catheter tip is inside of the artery. And in this patient, we could see also that the thrombus was here as well. So we had to go a little bit deeper. Normally, we don't go so deep. We stay here in M1 segment, but in this patient, we had to go to M2 segment. That is less studied in randomized trials. So here is the self-expandable stent that we are retrieving the microcatheter. As you can see here, we are retrieving this microcatheter here, and the stent is expanding. It's a self-expanded stent. You see 3 dots here. These dots are the 3 markers, radiopaque marks of this stent. So after a while, after 5 minutes, with interaction of the stent and the thrombus, we remove, just pull back here the stent. You see, the stent is attached to a 014 guide wire, and we remove that with aspiration. And here is the final result of this patient with this reestablishment of here before and here after of all these vases here, these branches pointed by the yellow arrows. So guys, I caught your attention here. I would like to get your attention for this thing here. This was performed by an interdisciplinary team. Myself and Dr. Orlando. Orlando is a neurosurgeon who has a huge experience in endovascular procedures. He is the one in Brazil that has the highest, one of the highest experience in treatment of cerebral aneurysm. He has a huge experience. So these work very well when here intervention cardiologists know exactly the hole that he has in the stroke workflow, and here the guy that who performs the procedure as well and work in a team in the interdisciplinary environment. That's the best mesh. When you have 2 specialties working together, you can see that the result is not 1 + 1 = 2, but 1 + 1 = 5 or 10. And we are running this project for a long time together. So again, here is what we removed from the patient with that stent retriever. You can see here some clots after interaction with the stent with the thrombus. And this is what we remove. So to close here the first part here with the case, this was our first case, you remember, acute myocardial infarction, remove of the thrombus with a final result like that with a STEMI 3. And this is our last case, as you can see, thrombus removal and a STEMI flow, TC flow to B3. That's regarding this classification, this was born from the STEMI classification. So a lot of similarities, as you have been noticing. So regarding, again, therapeutic similarities between primary PCI, not as the procedure, and mechanical thrombectomy, no one needs expertise in arteriovenous malformation treatment or arterial aneurysm treatment skills, or even skills in embolization. We don't need that to do primary PCI, and you don't need that expertise to do mechanical thrombectomy. Definitely. What we need is to have skills in reopening occluded artery, skills in thrombus removal. We need to know how to handle aspiration devices, aspiration catheters, to handle stents. Here, the difference that with this stent, it's definitely implanted in the patient, and here we use that just to interact with the thrombus and remove it. They are all stent retrieved. And then here we need, for dual antiplatelet regime, can stay 2 days talking about that. And here in acute ischemic stroke, we avoid the antiplatelet regime, not dual only, but any antiplatelet regime, because the patient, the thrombolytic, is on board. So about the workflow, so here the clinical evaluation in acute myocardial infarction with the delta time is a must that we should run against that. Is the same thing here in acute ischemic stroke. The delta time, again, I present time less known well, is the term that they use. So the EKG is what guide our strategy, guide our actions to run with this patient to the cath lab or not. Here's the neuroimaging, and I would like to get attention for these two first here, the non-contrast CT, and then the CT angiography. I will talk about it a little bit later. So here we need trained physicians in the emergency room and also cardiologists. And here we need trained physician, at least in the NIH stroke scales, neurologists that really are there, our boss here, and radiologists. Normally, we as interventional cardiologists, we take a more active position in the indications and the treatment. Here, we are like the boss is the neurologist. We should see that. And they should run the stroke workflow and indicate the case to be reopened. Of course, that with time, we get experience, and we can work together. But here, the neurologist will say, okay, this patient should be undergo to mechanical thrombectomy. And after a while, you see that the CT angiography that says this patient goes or don't, or doesn't to mechanical thrombectomy. So here in acute myocardial infarction, thrombolytic therapy is effective if you don't have PCI. Here in acute ischemic stroke, thrombolytic therapy is effective and is always used if no contraindication are observed and the time last known well is less than 4.5 hours. So you never avoid thrombolytic therapy in favor of mechanical thrombectomy. You can do both, and normally you do both. So if you are under 4.5 hours and there's no contraindication, there are a lot of contraindication even regarding the aspect scales. It's a long story here, but if there are no contraindications, thrombolytic is a must here in acute ischemic stroke. And the vascular treatment is the gold standard for acute myocardial infarction, and the vascular treatment is the gold standard, or has been the gold standard since 2015. Here we depend on a 7/24 available team on call or in the hospital. The same is true for acute ischemic stroke. Interventional cardiologists, we are many, and we are everywhere. And interventional neuroradiologists, neurosurgeons with endovascular capability skills, interventional radiologists, they are all of them very highly qualified. They are really good on what they do, but they are few if you compare with the burden of stroke that commit the world population. So what we have been talking about is to give a hand here in the stroke team, in the interdisciplinary stroke team. And I'm not just saying theoretical here because that is my experience. I work perfectly good, nice, with a neurosurgeon with endovascular skills. So just a glimpse on the stroke workflow. Of course, that's much, we should dive into this concept, but here we have acute ischemic stroke. Again, neurologists should guide all this workflow. They consider the time last known well, the NIH stroke scale, of course, that they will do clinical exams and some labs. And then the patient will go through imaging exams, as I mentioned before, non-contrast CT angiography, and here in a more advanced scenario, trying to see the perfusion, like perfusion CT angiography. I will comment about this a little bit later, but the must here is the non-contrast CT, first to exclude hemorrhagic stroke and to apply the aspect scale. And the aspect scale you will give you the notion about the risk of hemorrhagic transformation if you reopen the artery with thrombolytic, and of course with mechanical thrombectomy as well. So that's a very important scale. That scale will say to you, this patient will benefit, probably benefit from reopening the artery, and or will say that it will hurt the patient, risking to transform, to have a hemorrhagic transformation of this ischemic stroke. This is our EKG. This will guide the therapy if the patient goes to cath lab or doesn't. So here we need to have angiography, CT angiography, proven a large vessel occlusion. And in fact, it's a much more easy scenario. It's an easier scenario here because in this aspect, when you go to the cath lab, you know beforehand what artery is occluded. How is your aortic arch? How is, if there is any tortuosity or any disease in the carotid arteries? You can see all here before you enter the procedure. So when you enter the procedure and you go to the cath lab, you have already asked about your materials, which techniques with guiding catheter, long sheath, or even balloon guiding catheter. if you're going to go with a biaxial or triaxial system, if you're going to use a stent retriever or aspiration devices, and what is the size of your stent retriever. So this make a little bit our life easier if you compare with acute myocardial infarction, because even if you have an EKG showing pointing to the artery that's committed, here we have the precise location, the precise anatomy before entering into the procedure. So then after that, we can do the treatment. Of course, a lot of things to consider: timeless non-well, NIH stroke scale, aspect scales, and evidence of LVO, acute ischemic stroke. And if it's all okay, you will apply systemic alteplase and thrombectomy. And then we will evaluate the patient with the TC scale, that's the flow, trying to have a 2B or 3 flow in this artery. And then after patient discharge, you will evaluate, patients are evaluated with the modified Rankin scale. That is just a glimpse, just a small glimpse to show you, cardiologists, that there are a lot of things here that we should dive into this universe that is a fantastic universe, and our friends are the neurologists. So regarding now, it's not only acute ischemic stroke, and I will be always getting your attention about that. It's large vessel occlusion, acute ischemic stroke. We have these pieces of time from 0 to 4.5 hours, less known in well. Here, the delta time. If there is a large vessel occlusion, you should apply thrombolysis if there is no contraindication, and apply mechanical thrombectomy as well. After 4.5 hours, you cannot apply any more thrombolysis. Even there are some articles arguing about that, but the guidelines say to you now that it should stay up to 4.5 hours. Initially, it was up to 3 hours. Then if you go beyond that time, from 4.5, that's the limit for mechanical thrombectomy, 6 hours. And here you do it without thrombolysis. Then in an expanded window from 6 hours up to 16 hours with the diffuse trial, or 6 hours to up to 24 hours in down trial, you can bring some benefit for 1/3 of this population that arrive to your hospital in this window time. And this is a photo from the diffuse trial. It was published in 2018, showing how to select the patient in this extended window from 6 to 16 hours. And you evaluate exactly that first picture that I showed you, the necrotic core here, and you compare what is the penumbra, I mean the region under threat but still alive. And you can select some patient that you have a large penumbra and small ischemic core, and if you reopen this artery, you will benefit this patient, and you even reduce the risk of hemorrhagic transformation. So, but for that, you should have a CT, angio-CT perfusion imaging, dedicated softwares like this one. This is a must when you become accustomed to use it to do these procedures. So here, select the patient if you have a very nice workflow running in your hospital. So one main message that I want to give you is that the mechanical thrombectomy is an appendix, surgeon, dear friends, is an appendix of the stroke workflow. Before starting to think about mechanical thrombectomy, you should see if your hospital has all the guys neurologists running the stroke workflow. And after this wheel just working very well, you can adapt the mechanical thrombectomy like an appendix in this workflow. You cannot have a program of mechanical thrombectomy without having this wheel of stroke workflow, the thrombolysis application, and all the care and all the professionals dedicated to this. So here in this slide, I want to get your attention for some particularities on mechanical thrombectomy that you don't do with acute myocardial infarction. First of all, of course, when you do a acute myocardial infarction, you go put your catheter down to the coronary arteries. But here we have to turn up your catheter, and to handle supraortic vessels sometimes is the most difficult part of the procedure, even in aortic type 3 or in those are aortic type bovine, that you have to approach the left carotid artery, left carotid system. So here you should manipulate very well supraortic vessels. You should know a lot about cerebral vascular anatomy, the arterial anatomy. You should dive into this aspect, and you should dive in how to use dedicated materials. You should know all the materials. You have a lot here, and very good materials. Aspiration devices, stent retriever devices, biaxial system, triaxial system, guiding catheter, long sheath, balloon guiding catheter, all systems that you can select like a tailored procedure for a specific patient. And you know that I like very much this concept. So my dear friend, we have been talking about this for a long time. I have two really professors and friends and brother that are Dr. Roberto Cremonese and Fausto Castriota. I have been with them for a year in a fellowship from EuroPCR in 2007, and we did a lot of things, and I have been doing a lot of things together. And in 2012, we proposed a classification regarding the anatomical piece that you have to think about when performing carotid artery stenting. Here I'm talking about the cervical carotid artery stenting. And we create the obvious classification, but you should pay attention in all aspects, anatomical aspects of each of these segments to plan and to tailor the procedure to a specific patient. And you should know how to handle the devices here. And it's of course that this interventional cardiologist that has a carotid artery stenting background has this advantage. This is what we did, and we wrote this book with technical aspect of carotid artery stenting. So those professional surgeons, they have ability, skills to handle the supraortic vessel. That's very important. I would say that that's the most important part of the procedure, to have a stable catheter in the internal carotid artery. That is very important. That's the very first step, and maybe the most important one. So with the devices, we started to create here our Empire states. So here we have the balloon guided catheter. That can be the balloon guided catheter, the long sheath, or even another device. So we start to consider, then we have with the distal access catheter, then the microcatheter and the microguide. You can go with this first two, like a biaxial system, or using the three, like a triaxial system, and then remove the guide wire, and you can do the stent retriever, or you can aspirate through the distal access catheter. That's called reperfusion catheter or aspiration devices. This one, the blue one. So if you have carotid artery stenting background, of course, and MOMA device use. They are very similar in concept of this one. And here, this long catheter works like extension catheter. Just make a relation, a comparison with interventional cardiology. Microcatheter, we use it normally in chronic total occlusion. Here, guide wire is almost the same. Coronary stent, carotid stent, they are self-expandable, so they work pretty the same here as stent retrievers, and aspiration catheter that we have shown just a few minutes ago. So, Serjan, this is the first part, the most important one, and it took about 40 minutes. But these two parts here, they are much shorter. They are shorter, and we can go. Do you have any question regarding these, or should we finish the presentation to ask the guy to have any comment about the guys?
Yeah, I have some questions, but let's finish the presentation, and then our friends will also write questions, and we will ask to you.
Okay, so regarding the burden of acute ischemic stroke, the incidence of acute ischemic stroke in the United States about 750,000 patients annually. In Europe, the thing is not different. The situation is not different. About, again, 750,000 cases of new patients with acute ischemic stroke. If you see this publication, it was published in 2019 in European Stroke Journal. 7.3% of incident ischemic stroke patients receive intravenous thrombolysis. The highest country rate was 20.6%. Regarding the endovascular treatment, about 1.9% of incident ischemic stroke patients receive endovascular treatment. The highest country rate was 5.6%. So, excuse me. There is a difference among the countries regarding the availability of treatment, of endovascular treatment. Should not go into detail here, but of course that is a regional difference. And in Latin America, the situation is not different. So we have about 600,000 new patients suffering from acute ischemic stroke. So about 260,000 deaths from stroke annually. About 5.5 million of stroke survivors here. And I think that Brazil, we have the highest prevalence of stroke among other countries. It was a very nice paper published by Dr. Sheila Martins. I'll talk about her a little bit later, but she's our leader here in Brazil. She's leading all the process. And thrombolysis is available in only for less than 1% of Latin American population. Could imagine that. This was published in Lancet Neurology in 2019. It's a very recent publication. In Brazil, the thing is a little bit better. It's 2.8%, still very, very low, but it's a little bit better, 2.8%. It's just estimation, it's not in the article. So mechanical thrombectomy, if you think about the procedure itself, it's even for a fewer patient. You cannot apply the chemical lysis, thrombolysis. You cannot imagine regarding the mechanical thrombectomy. So Dr. Sheila Martins, she's just pushing the boundaries here in Brazil. She's the vice president of the World Stroke Organization, and she's brilliant. She's doing a very, very good job in Brazil. Compliments for her. We have here Rede Brasil AVC, that's a net of stroke centers that she's leading as well, as a huge effort to reduce the burden of acute ischemic stroke. And we have another movement here, that another project, that's the Angel project, that is from Bering, and it's a very nice project in terms that it helps you in the basic parts of implementing a stroke workflow in your hospital. So I know that the Angel project is in many countries around the world, and in Brazil it's working very nice. In the 2 hospitals that I work in, 3 hospitals, 2 hospitals, they helped us a lot in implementing all the stroke workflow. I think you can find it in the internet with this name. So regarding the role of interventional cardiologists in the stroke team, so again, there is a point in the timeline that everything changed. Now you know very well, just to repeating to you many times. You see that all the trials that I mentioned to you, these are the 5 trials: the Mr. Clean, Escape trial, the Extend 1A, Revascat trial, Swift Prime, and then we had 2 years of Mr. Clean, and then more 3 trials in the following years, FIST, Therapy, and Trace. And then after that, we had in 2018 the publication of 2 very important trials that expanded the window, therapeutic window for acute ischemic stroke in terms of mechanical thrombectomy. This is diffuse from 6 to 16 hours, and here the Dawn trial from 6 to 24 hours. So here is the game change. These are the timeline of these randomized trial. Just to show you about a finding with the Hermes collaborators in this big meta-analysis that they did, that the NNT, number need to treat, with the endovascular thrombectomy to reduce disability by at least just one level on the modified Rankin scale for one patient was 2.6. 2 points about, if you want 2 points, it will be, I think, about 4.6, but it's too low. It's too low. The benefit is so strong. You can compare this strategy, this treatment in large vessel occlusion, acute ischemic stroke, only with the use of antibiotics in the sepsis shock. So here is Sweden. It's a very egalitarian country, a universal healthcare system here, and they are worried about that. Some cities are 1 hour from a stroke center, pointed here by orange, and other cities are not. And they are thinking to initiate an action in Estevao, planning to train interventional cardiologists in an accelerated rhythm, just to cover these other areas here that some part of the population has access and others don't. So the guideline from the American Heart Association here and the American Stroke Association, they joined together to create this guideline, and this guideline is class 1A to have center capable of performing the vascular stroke. This is a must. We should provide this. And we know, this is a very interesting article published in 2018, that if you transfer those patients, you impair the eligibility for endovascular stroke treatment. So the ideal scenario, if you have a hospital, you can provide mechanical thrombectomy for your patient with a good rate of success. That's the best option. And here are some articles that talk about interventional cardiologists and mechanical thrombectomy. This is a must to read. It's only 2 pages. It's an editorial written by Dr. Nick Hopkins, Nelson Hopkins, and David Holmes. It was published in 2017, and it's a must read. I will comment about some phrases about this article. So then come Peter Lancer with that article that I showed you, the timeline. ischemic stroke and ST segment elevation, myocardial infarction, fast track single stop approach, and then acute stroke intervention, the whole of intervention cardiologist, written by Dr. Christopher White. Very good article as well. And here David Holmes again with Dr. Nick Hopkins, intervention cardiology and acute stroke care going forward. Here's a neurosurgeon, excuse me, Nick Hopkins, neurosurgeon. So here is another article that show us that intervention cardiologists center in close cooperation with neurologists could apply direct catheter based. And it was written by Peter Winsky and also Omer Gotkins from your country, surgeon. You are in a good position. Omer Gotkins has a huge experience on that. Here's another paper written by Omer Gotkins. I had the pleasure to meet him at EuroPCR in a session that I will mention to you. And the vascular therapy of acute ischemic stroke by intervention cardiology, single center experience from Turkey. It was published before, even before the 2015 boom of endovascular treatment. You should follow this guy. So predictors of outcome following catheter-based therapy of acute stroke. This was written by Christopher White and A. Hartlight. And the conclusion is that this study demonstrated that intervention cardiologists participating on a stroke team achieved comparable outcomes to neurointerventional specialists. So that is the term. If you forget everything of this presentation and stay with this in mind, I would be very happy. Interdisciplinary team. We have in the Oxford Learner Dictionary definition is the quality of or factor of involved different areas of knowledge or study. It's a good definition. The other one is not so scientific, but it's from Wikipedia. But I would like to give it to you is the concept that involves the combine of two or more academic disciplines into one activity. It's exactly what happens in stroke team. It's happening in my hospital. So we have been working together, myself and Dr. Orlando Maya, for almost 13 years in the stroke program. And I put here harmonically. There's no competition at all. Everyone's know its specific role in the stroke scale and the stroke workflow, excuse me. So here we try to do our best for the patient. And I gave just some speech in the EuroPCR 2017 about the interdisciplinary team. And we had there Omer Gotkins, the chairperson, Nick Hopkins as the chairperson, Michel Piotin here on my side, and Bernard Heimers, Horst Sieverts, and also Dr. Alberto Cremonese. It was here. We cannot see him, but he was here just watching and participate on this meeting. And the main purpose is to understand the strategy planning and procedure step for cardiologists. So there was raising a question about what do you call, what do you define, how do you define training for interventional cardiologists? And of course, I started to think a lot on that. And I came across with these three concepts, these theoretical lessons, of course, a lot of, to know all the stroke workflow, all the materials, all the complications, all the aspects that we have to face in the workflow and the mechanical thrombectomy procedure. Device manipulation, of course, we need to know a lot about that. And this, the biggest wheel is virtual simulation. That, I think, is a game change in the training of acute ischemic stroke, virtual simulation. But not that concept that use with one virtual simulation for 10 or 20 people. For me, it doesn't work at all. Should have one virtual simulator for 2 people maximum. So the guys will be performing the procedure all the time. as a first operator or as a second operator. And of course, that it will be all in an interdisciplinary team. So this is the course that I'm running now in Brazil. It's a 5-day full immersion course. It's a very intensive course. I must say to you, we use virtual simulator, at least 20 cases, just put on the physician's head, all the aspect, all the steps of the mechanical thrombectomy, give at least 20 hours, handling dedicated devices, and a pre-work with many, many articles to read before arriving the course. This course is running into the Global Research Center from GE. We have only 6 centers of these in the world. One is here in Rio. I'm very fortunate for that. And in this center, we have all the capabilities to run the very high level courses here. And this is the structure of the center with all the capabilities that you need to stay with the guys here for all the week without them going out. You only go out to sleep, but we stay here in a very intensive project, in a very intensive course. And here, what we do, a couple for each devices, a couple for each simulator. And this is a very specific simulator that we have been using in the course, very realistic, I must say, very, very realistic. If you know how to use this tool, and if you respect this tool as it should, then you are going to have very good results with your operators. So this is my last word. I think that we are approaching about 1 hour of presentation. As I said before, I would like to come back with this article published by Dr. Nick Hopkins and David Holmes, Circulation 2017. I took a photo from the article, and I would like to read to you that the new data have a result, I mean the 5 randomized trials that I present to you, the new data have a result in a potential cataclysm gap between patient need and available expertise. Therefore, we believe interventionists from other training backgrounds must now fill this gap in acute ischemic stroke, and a collaborative ST segment elevation myocardial infarction STEMI model for care needs to be instituted to ensure rapid revascularization. The article goes on. So Dr. Nick just stated that interventional cardiologists appear well suited to take on this task. They are accustomed to 24/7 STEMI coverage and are highly skilled at reopen occluded arteries. Interventional cardiologists spend most of their working hours opening stenosed or occluded arteries in the heart with techniques and goals similar to those required for stroke intervention. That's very true. When they ask us to occlude an artery or to embolize an artery, it's not our nature. Our nature is to reopen arteries. So, and in the United States, more than 6,000 interventional cardiologists currently in practice, and the cardiology STEMI infrastructure is already in place, with more than 2,000 cardiac catheterization. So, my friends, I think that we have approached about 1 hour and 2 minutes of presentation. And like Dr. Carlos Mestre would say, I have achieved the goal at least with the time. So I give you my contacts here if you wish some information. And I'm open here now at your disposal to try to answer any questions regarding this presentation.
Thank you very much, Estevao. It was really excellent presentation. We learned a lot, and there are many questions. So let me ask the first one to you. The Dr. Inanç asking, how many endovascular interventions were performed for acute ischemic stroke in your hospital per year?
How many interventional cardiologists?
How many stroke interventions do you perform in your hospital per year?
We are not a very high volume center. We normally do about 4 cases a month, or sometimes 8 cases, sometimes 3 or 4 cases, and but we should have at least 30 to 50 cases a year in your center. And for example, the net is expanding, surgeon. For example, I work in the Brazilian Air Force Hospital, and this is the number of patients that came to my hospital. And you have to put a lot of effort on the project. And sometimes some guys has to lead the project in terms of enthusiasm. And I think that we have these kind of characteristics as well. And what we are doing now is to create a net among all the 3 hospitals from the Brazilian Air Force in Rio de Janeiro, with some apps like the Join apps, like some other apps that make some communication among these hospitals. And we are thinking that we are going to achieve about 10 cases a month. That is our projection.
Dr. Uzaleskin had question. She asking that, have you ever had conflict in terms of authority with interventional radiologists?
Yeah, we have been discussing about that. The most important thing, surgeon, is it's not a competition for a procedure, as I have this experience to tell everybody, as I work in harmonically environment with Dr. Orlando Maia. When he was 100% secure that I didn't want to invade his procedures, his profession, but I wanted to help, and he was just one in my hospital, and my hospital needed that. And he had to travel, he had to have some free time, you know, and it was a natural process, I must mention. It was a very soft process. It was not, oh, I want to do this procedure. We started much before 2015 boom of randomized trials. So the thing that I want to show the guys is that this partnership can solve a lot of problems. And if the guys have this predisposition to hear us, because you can give a very good hand for them, but we should stay on acute ischemic stroke intervention. Maybe that's the main problem. Maybe the guys could be insecure about if the interventional cardiologist now will do cerebral aneurysm treatment or arteriovenous malformation, embolization, or something like that. That I don't advise to do. That I really stay on reopen arteries. That we are very skilled on that. I advise it very hard because it's what I believe. So I never tried to embolize an aneurysm in my life in these 15 years that I have been doing this procedure. I think if you want to do, I think aneurysm embolization should go to a specific, very specific and 2 years training with neurointerventionalists. But it's not what we're talking about. We're talking about, and in fact, the population the population doesn't need that. There are a lot of guys doing it very, very well. What the population needs is to receive the treatment to reopen an artery for acute ischemic stroke, and acute ischemic stroke is not an elective procedure. It's an emergent procedure, and should have a lot of people work on that workflow, a lot of people. And if you say that, and that is my experience, I can say that very easily, that you can work in a collaborative stroke team in favor of the patients.
Yeah, this is a really important point, thank you. The Dr. Iskender from Azerbaijan asking to us, if patient's GFR is less than 40, or if patient is on hemodialysis with acute ischemic stroke, which treatment management will you use for these patients?
Yeah, all the decisions are made by the stroke team, And as I mentioned before, the neurologists, they will stay with us deciding. It's different, the position, surgeon. We are not running like we do in acute myocardial infarction, that we should just go there, see the EKG, and analyze the EKG and say, oh, this guy is coming to cath lab, or even by a phone you do that. In stroke workflow, as I mentioned before, we are an appendix of this workflow. So the decision should be taken by a team to see the risks of mechanical thrombectomy, and then, of course, to evaluate as a team if the patient goes to the procedure or not. So, of course, if the risk of the patient to receive thrombolysis is high, and there are some contraindication for that, you go only with mechanical thrombectomy. So if you think that the association of both treatment is always better, but in some specific scenarios, like the first one that I shown to you, that there was a contraindication for thrombolytics, you could use only the mechanical thrombectomy.
There are many questions. Dr. Uzel asking that during intervention, do you need anesthesia for the patient? How
we need the professional there, of course, but we don't do general anesthesia. There are some papers showing that general anesthesia can make the things worse for the patient, because it can induce a little of hypotension, and it's not good for a brain during the stroke. So normally, in 99% of cases at least, we do conscious sedation, not general anesthesia.
Yeah. And there is another good question. What is the frequency of hemorrhagic transformation after thrombectomy in your experience, and what are the predictors of this? I mean, it's operational or patient-related factors.
So it's a very good question, Sir John, very good one. So the transformation is very low. Why this is very low? Because we work in a stroke team. So the selection, the procedure is not that difficult to perform, Sir John. As I mentioned before, the most important thing here is to have a very good workflow running in your hospital. That's the most important thing regarding any project. I told this at the beginning of this presentation. There is a wheel that is called stroke workflow, that's led by neurologists. And here, if you want to adapt an appendix of mechanical thrombectomy, you will be welcome. But this central wheel is the most important thing. So selection, not the procedure, but selection is the most important thing to reduce the hemorrhagic complication of your procedure. Of course, my friend, that you should be very delicate. You should use a very specific techniques. You need to have a good hand to know all the devices, to tailor your procedure for the patient. Of course, all these things matter for not incurring in hemorrhagic transformation, but the most important thing is screening your patient for the mechanical thrombectomy procedure. When you achieve that, Sir John, my friend, when you have a team working with you, of course, that your result, not your personal result, surgeon result, or the guy who did this question, but the team result, the hospital result, because everything will be watching you. That is a reality. So if you have one complication, because, oh, I want to do the procedure, I'm very anxious to do the procedure, you will be broken. You'll be dead, you and the patient. So we should be very calm on that. Try to put all the structure and surround you by very good professionals. That's my advice. Of course, with time, you will get used. You will know some points in the workflow, but this responsibility is with our friends neurologists.
And another question. Dr. Karakush is asking one of questions that I plan to ask. He is asking, do you accept observers for training in your own clinic? And what are your recommendations for training? I mean, we really get inspired from you if you want to start the stroke intervention, how we should begin.
Yeah, as I mentioned, we work in a center that performs 8 cases, 6 cases, sometimes 4, sometimes 10. It's very unpredictable. But this course is really a course that is that I led here in Rio. That's a very interesting course. It's not the solution for nothing, but it's a very good hand for the guys who wants to dive into the procedure, into the concept. It's a multidisciplinary, it's an interdisciplinary course that we have a lecture with neurointerventionalists like Dr. Orlando and his team, neurologists, neuroimaging specialists, and virtual simulators. So yes, this course will be my very good advice. But I should also mention that in Europe, you have a very good centers like Dr. Omer Gotkins. I don't know if he accept fellows, but I know he has a very huge volume there. And here in Brazil, in Rio, I can offer the course. The course is a very good step for that. It's a very good introduction for this world called mechanical thrombectomy for interventional cardiologists.
There are many questions, Estevao, so it's really bubbling here.
Okay, my friend. Let's try. I will try. I will keep trying to answer the questions. I'm just enthusiastic of this procedure.
Dr. Kochit from Turkey, she is asking, does your approach differ for an early presenting patient with acute ischemic stroke that is already under the oral anticoagulation or NOAC?
Yeah, that's a contraindication for thrombolytics. Again, I will also say the stroke team will decide what to do, because when the patient arrived to you is because the decision has been made before, and but of course in these patients I will try not to use thrombolytics, and after screening the patient with the CT angiography, the angio CT with a proven large vessel occlusion, and after discussing with the neurological team, I will do only, if all they agree, only mechanical thrombectomy for this patient.
Yeah. And there is another question about your country. Dr. Kochit asking, why do you think Brazil has the highest prevalence of stroke in LATAM, and what is the main predisposing factors in Brazil? What do you think about this?
Yeah, we have a very heterogenic population here in Brazil. Some people with very high level in terms of social quality of life. We have a lot of poverty here in Brazil, unfortunately, and maybe this is one of the main causes for that. A lot of people that has hypertension and are not receiving a medication, but it's multifactorial, Sir John. It's a lot of problems that as a developing country we still face.
Yeah. And Mohammed, if you can open your mic, can you ask the questions?
Excuse me?
The Mohammed asking a question. If he wants to open the mic, he can ask by himself.
Hi, Estevão. Great presentation as always. I really enjoyed it and I learned a lot. So, Estevão, I wanted to ask, and I guess you alluded to the answer, but after the procedure, because I've always believed that, and I still sincerely believe that doing procedures in general are really not that difficult. I can train any high school dropout to do PCI, to do MitraClip, to do TAVR. What's really important is the care before and after. Do you personally take care of these patients aside from the groin access side and basically the technical issues? Who takes care of the stroke patient afterwards? Do you have a stroke team that they do nothing but taking care of stroke patients, or these are just any neurologist who happens to be on the neuro ICU service that particular week of the day, or day of the week rather?
I'm not seeing here the video, Serjan. So I don't know if I'm. Can you see me now? No.
Yeah, I send you a request.
But we can't hear you though.
Okay, let me see. It's okay. Now I'm back. Just a second. Okay, my friend Mohammed, how are you? Thank you for your question. I'm very happy to see you here.
Yeah.
As
Thank
always, you are very enthusiastic of all the new projects. So thank you for the question. So regarding these, as I mentioned before, we work as a stroke team. You know, every part of the team has a specific role, and for sure, I can go to visit the patient, but not take responsibility of this patient after this patient has been treated with mechanical thrombectomy. So the neurologist, they will do these activities. So as I mentioned before, there is a wheel, that's the workflow that has been running for a long time in many hospitals. But if you want to attach an appendix of this wheel with mechanical thrombectomy, the wheel will keep running by itself. So the neurologists, they are really the boss here, Mohammed. And they will try, and they will not try, but they will decide with us which patient should do, which patient will receive the thrombolytic therapy, which should go on mechanical thrombectomy, and also which patient will be followed by a more specific team. So if you see that not only the neurology team is very important, but also just to having as a back on your back the neurosurgeons, because the neurosurgeons, they are not called very frequently, but they should be there not only for mechanical thrombectomy complications, but for thrombolytic complication. If you apply thrombolytic in a patient and this patient suffer hemorrhagic transformation, you should have neurosurgeons to give a hand to this patient. So coming back to our questions, after doing the procedure, you can go to the room, you can go visit the patient just to give a hand to the guys, but the responsibility is with the neurological team. Is that your?
And can you also, yeah, that's great. Can you also comment on the management of hypertension in case that the blood pressure is over 180, 190? Does it really matter because you've done an intervention in terms of management, or you still follow the same neurology guidelines in terms of post-stroke hypertension or hypertensive episodes?
A very good question, my friend. So we have two different moments: the moment before reopening the artery, and the moment after reopening the artery. So we avoid definitely hypertension in those patients with an reopened artery, because we will have, in a good scenario, good flow in the artery. The thrombolytic will be on board, and the brain has been damaged somewhat. So what you should avoid on that specific moment is hypertension. So you should follow your patient in intensive care, and if you have a dedicated neurological intensive care, it will be very, very good for your patient. So avoid completely hypertension after reopening the artery.
What's your cutoff point? Beyond which you aggressively, is it 180, 160, 150, 200? Is it
about pressure? Systolic pressure about 140. If you say about systolic pressure, that would be our target.
So in terms of the blood-brain barrier, the perfusion pressure to the edematous brain, don't you want to have a higher blood pressure then?
Yeah, there's a damaged brain there. The barrier is damaged. So if again, if you put high pressure there, because the brain was working, it's different, my friend. If you compare, for example, like a procedure that you do in a carotid artery that has been for a long time with an occlusion or with a very severe a lesion, and your brain somewhat accustomed to work in a very low pressure. So we should be very, should have a lot of care in reopen tight stenosis in the carotid district, because it can cause a reperfusion syndrome, because even if the pressure is okay for those patients, the brain was accustomed to work in a low pressure regime, and sometimes the autoregulation will not work instantaneously, and it can cause the syndrome called hyperperfusion syndrome, and it can impair the situation in the brain. The situation is different because you have a normal brain, but the autoregulation is not working very well. In the brain, in the stroke, you have a damaged tissue, and the amount of the damaged tissue, you can evaluate this through a aspect score scale that you can see the CT. That's the first exam that you do in the patient, the CT tomography, and to see if there is any sign on the CT tomography if the brain has been already damaged for this stroke. So it's why you have a cutoff in this scale that is about 6 points. You start with 10 points, and this aspect scale, you give a point for 10 regions irrigated by the middle cerebral artery. And if there is a region in these 10 regions committed by affected by the stroke, you remove a point. So you can remove until 6 points. If you have a stroke scale about 6, is your limit. If you have a stroke scale, aspect scale, excuse me, of 5, 4, 3, don't do the procedure. Don't do the mechanical thrombectomy. Don't do the thrombolysis, because you can transform this damaged brain, this damaged tissue, and it's not talking about regulation, it's about lesion, into a hemorrhagic stroke. That's why the first question that the guy asked us about the rate of hemorrhagic transformation, it's very related to the screening of the patient that you do. So you have this workflow working and selecting correctly the patient. Yeah, you will reduce your complications, will achieve better results and better clinical outcomes for the patient. But what we need here, and what we have focused on, is on the recovery of this patient in terms of functional independence. So if you have a low ranking scale at the end, it is our goal for these patients.
Thanks, Estevao. It's really a fantastic presentation. So we are now even 30 minutes over time. So we have come to end of today's online program. So thanks again to Estevao for this excellent presentation. And thanks to you for the great participation. So now I request, if possible, to open cameras, and let's wave our hands to say goodbye. Is it possible to open some cameras if it is okay for you? Very beautiful. Yeah. Yeah. The best part of it, huh? What do you think?
Yeah, very nice.
Yeah, okay.
Yeah,
so
all the
goodbye.
faces. So
goodbye. See you.
See you.